Hello, everyone, and thank you for attending and coming from wherever you are. We appreciate your time. I'm Dr. Peters. I'm one of the bariatric surgeons at the Christiana Institute for Advanced Surgery, or CRIAS. And you've been referred for evaluation for your bariatric condition. I'd like to give you some information today that would help you make decisions regarding your treatment, whether they choose to be medical or surgical. The Christiana Institute for Advanced Surgery, by way of information, is a group of general surgeons, all with specialty training in bariatric surgery and now expertise in medical therapy for weight loss. Throughout the state of Delaware, we are the most experienced bariatric surgeons you will come across. We have helped 3 institutions locally achieve their Center of Excellence status, both within the hospital systems and outpatient settings. We also serve as general surgeons for the community, performing gallbladder surgery, hernia surgery, reflux surgery, cancer surgery, and a multitude of other general surgical procedures that you could find in any healthcare setting. We are a large purveyor of the robotic platform. For those of you interested in robotic surgery, we have specialists trained and fellowship trained in robotic surgery and can easily perform general surgeries in that fashion. In our practice now, we have approximately 7 surgeons: Dr. Isaiah Irgao, Dr. Nguyen, myself, Dr. Raul Singh, Dr. Pakar, and Dr. Hoy are our bariatric surgeons. And we have Dr. Vade, our colorectal surgeon, for specialty issues regarding the colon and rectum. With respect to what you've been referred to is the treatment of a medical disease called obesity. Obesity is a failure to dispose of excess stored fat. And with respect to what obesity is, we need to define that with respect to a height and a weight variable. This is called the body mass index. It is by no means perfect, but it is what healthcare practitioners utilize to describe obesity and the degree of severity within the population. As you can see by the slide on your screen, someone who's reached obesity class 1 would be 175 pounds at a normal height. And this can range anywhere from 5'4" to 5'6" in the right individual. As we climb with respect to obesity and body mass index, we become surgical candidates and/or medical candidates based on the severity of not just the obesity, but of the conditions affected by the obesity, called a comorbid condition. With respect to the causes of obesity, it's a multitude of factors. We as a nation have achieved great independence from manual labor, and this has been a boon to our productivity. However, as a result, there is more sitting, there is more computer dependence, there is more cubicle dependence. And as a result, less physical activity has resulted in less calorie burn. So our environment has changed dramatically. Our behaviors have changed as well. We used to be a nation of walkers. And currently, if you can find areas where walking is more common, you will find a lower average body mass index. However, with respect to driving, our now cubicle environment at work and our driving up to 30 to 45 minutes to work every day constitutes a period of time where no calories are burned and actually calories are added. Our culture also contributes dramatically, as we are one where we celebrate events with food. And food is joy, or food is love, has often been inscribed in our environment. Our genes as humans help us gain weight. And how does that happen? Well, a little bit of excess weight is a safety mechanism on the body. And our genes are designed to provide safety for us and add that weight to our bodies. However, our genes are not aware that we are no longer hunting and gathering for our food. Currently, we can drive to a local Wawa to hunt for food, and it's not always the best quality. With respect to morbid obesity, it's often not the size itself that's the problem. It is the comorbid condition that the size causes. Morbid obesity drives things in a microvascular inflammatory condition, such as a migraine headache or a fatty liver. It can even worsen or cause or be the source of diabetes. People with asthma, sleep apnea, and depression all can blame obesity to a degree. We see a dramatic reduction in these issues with weight loss. The treatments for obesity range everywhere from simple lifestyle changes up to surgical intervention. We now have significant medical management that can intervene as well prior to surgery, although surgery is the most definitive, best quality, and guaranteed to give the longest lasting results. Medications are lifelong, and that needs to be known. Diet and exercise may not be enough. We're going to get into some statistics regarding diet and exercise and see how actually poor they are. However, it results in a feedback loop where there is weight loss during a period of essentially starvation and excess calorie burn. This results in a system resetting, believing that there is food scarcity. And as a result, the metabolism will drop because the body believes that we no longer have nutrients available to it to sustain it. As that metabolism drops, hunger will increase. Hunger increasing with a lower metabolism results eventually in a rebound. There's an excess intake of calories on top of a lower metabolism, resulting in weight gain and very familiar weight overshoot from the original weight. This is very frustrating for patients, and this is when we tend to see our patients present for therapy. Now, why bariatric surgery works is it breaks that cycle at the top of the weight gain. What happens is our patients undergo a procedure which overdrives the weight loss beyond simple starvation and hunger to a point where their actual metabolism and hormone levels will reset. At this point, they understand that the environment is not nutrient scarce, but rather is the new normal. And the nutrient sources are smaller, more efficient, better quality, and patients are able to sustain that weight loss after that significant drop, thus breaking the repetitive cycle. Now, bariatric surgery, if we take a look at the statistics with respect to diet and exercise, you can follow across at the top of the table where diet and exercise long term, we're looking at 3 to 5 years of routine diet and exercise, show very little weight loss, averaging at 0.1% for a 3 year evaluation and about 1.6% total weight loss in the average population. Now, it's important to remember that that is not any significant weight loss. However, it's not any significant weight gain either. And that's important to look at that because we're going to use that as we get into our pharmacotherapy or medical management and also our surgical management. The pharmacotherapy has changed over time. Medications from the 1980s and 90s have been replaced essentially with new medications from the 2020s, such as growth-like peptide, things like Wegovy and Ozempic. These numbers are still early. We don't have enough long-term data to see where they are, but we can tell our patients with definite answers now that the medication will be lifelong and the weight loss will be highly variable from patient to patient. Gastric bypass and other bariatric surgeries have been around since the 1950s, and weight loss for these is very well defined as well as the long-term outcomes. They are a permanent condition, just like medication, and they work very well. Now, our gastric bypass operation, which used to be the gold standard for procedures and was done most routinely here in the United States, will result in about 50 to 80% excess body weight loss at 1 year. Typically, that rebounds, and at the end of 5 years, a total excess weight loss of 70% can be achieved. A sleeve gastrectomy, 50 to 75% excess weight loss at 1 year, with approximately 50% maintenance weight loss at 5 years and longer. Gastric banding has faded and is more of a historical procedure at this point. We would see patients with excess weight loss at 1 year of about 40 to 50%, and long term, the data was not as good, with a total weight loss of about 30%, still better than the average pharmaceutical therapy, and certainly better than diet and exercise. However, bands still remain the only reversible weight loss surgery and are still sought out by a select few. With respect to the most aggressive surgical intervention, we have what's called a DS or duodenal switch. This operation can be utilized in the face of super morbid obesity or patients who have failed pharmacotherapy as well as previous bariatric surgery patients who have regained some weight. The institution of the duodenal switch requires very strict adherence to vitamin therapies and dietary monitoring. It is not to be taken lightly. Now, who is a candidate for bariatric surgery? We are an adult practice. Our patients will be 18 years or older, and certainly they must meet certain criteria with respect to their weight. This is not a cosmetic procedure. The National Institute of Health wants patients to be a body mass index of 35 or higher and have significant comorbidities. Patients should have failed a medically supervised weight loss attempt. A patient should not walk in off the street and say, I decided last night I'd like to have surgery. They must undergo evaluation, be able to understand the surgery and risks, both intellectually and accept the operative risks. All right. A patient who is not acceptable with respect to an operative risk might be one who's too sick to undergo any surgery, and bariatric surgery would be inappropriate. They must be ready to commit to lifestyle changes. They must have the insight to understand that after bariatric surgery, their nutrition sources will be vastly different than what they might find at a routine convenience store. They will be shopping selectively at the supermarket in the quality areas such as the vegetables, fruits, meat, and dairy sections. The most common procedure we currently perform is a sleeve gastrectomy. This slide shows us the anatomy of the esophagus and the stomach and the remaining intestines. You can see the stomach is cut from the bottom to the top and creates a vertical sleeve. The remaining stomach, approximately 80% of the stomach, is removed. That's what ectomy means, removal. So this operation will remove 80% of a normal appearing stomach and leave you with 20% of your stomach, resulting in about 50 to 75% excess weight loss at 1 year. It works in a twofold fashion. Number one, it restricts how much food can actually be accepted by the stomach. You feel full very quickly. That sense of satiety or fullness registers much more quickly than it did in the past, and you simply stop eating. The second way it works is more of a hormonal mechanism. The larger part of the stomach, called the fundus, up near the top of the stomach, is removed, and this is where ghrelin, a hormone that stimulates hunger, is found. After this procedure, if one was to check your ghrelin blood level, it would actually be lower. This can often last for a year or longer in patients, and they will feel satiety throughout the day without hunger, much like some of the GLP medications are touted to work. The second most common operation we do today is the gastric bypass, the classic bypass anatomy. This operation results in no removal of any organs. We do use the top portion of the stomach to create a small pouch and then route the intestine up to that pouch so that food will travel all the way down and nutrition will be absorbed. The rerouting involves 5 feet of intestine where nutrients are not absorbed and neither are calories. Over this 5 feet, along with the pouch inducing early fullness or satiety, these two mechanisms result in significant weight loss. The malabsorption results in more weight loss than a gastric sleeve on average, and we can state that at 1 year, about 50 to 80% of your excess body weight can be eliminated. For our patients who undergo the gastric sleeve and the gastric bypass, since the inception of this presentation, we are now doing these as an outpatient, and patients will have their procedure performed over the course of approximately 60 to 90 minutes and typically be back in their homes in about 6 or 7 hours. Gastric banding, again, as a procedure of the distant past, is a procedure we do outpatient. It takes approximately 30 minutes. It is the only reversible procedure. It does need frequent adjustments in the office. You do need to come for follow-up. And again, the weight loss far less superior at 40 to 50% of excess body weight loss at 1 year. And finally, For those patients suffering from supermorbid obesity or who have failed weight loss medications and or surgery in the past, we recommend the most aggressive operation, which would be a duodenal switch. It can be formed in a loop or classic formation, but this is currently a hospital procedure. It is done and usually has an overnight stay. The excess weight loss here at 1 year is typically 75 to 85%. Now, bariatric surgery, like any surgical procedure, has the potential for complications. The common complications of any surgery would be bleeding or infection. These are very low at less than 0.25%. And hernias and blood clotting to the lungs are also running around 0.25%. Other complications are more subtle. Rapid weight loss in anyone, whether it's due to surgery or due to medication, can result in gallstone formation, resulting in a gallbladder attack. Malnutrition can result from undereating, and we recommend follow up with a nutritionist several times during the first year after surgery to make certain vitamins are being taken and protein requirements are being met. Wound infection is very rare in bariatric surgery due to the laparoscopic approach, and blockages in the intestine are now very rare as gastric sleeve and decreased adhesion formation are more common with the laparoscopic approach. Vitamin or protein deficiency is constantly monitored by either blood draws from your bariatric surgeon or your family physician. We evaluate this routinely. After surgery, there can be a narrowing where connections are made. These are dealt with surgically or with dilation. Leaking, typically not seen, runs about 0.25%. Ulcers will be seen on bypasses, typically if smoking is performed. However, ulcer formation typically runs about 2 to 3% on a gastric bypass, very uncommon on gastric sleeve. Issues like nausea, vomiting, or dumping are typically transient and resolve very quickly after the first day or two, if they are even seen. They were typically more related to anesthesia in the past, and our anesthesia techniques have improved over the last 20 years. Dumping syndrome will occur in bariatric patients who eat more sugar than is recommended. The sugar will not be processed appropriately and seems to run through more like a laxative than anything else. The health improvements you can expect after bariatric surgery are a multitude. With respect to people who suffer from migraine headaches, we see over 50% resolution. Patients who suffer from failure to ovulate with polycystic ovarian syndrome type disorders, we can see well over 75% resolution and improvement and an increase in fertility. Patients who have diabetes often do not need to take medications again lifelong, and the risk for cardiovascular disease drops significantly as there is less lipid within the bloodstream to clog arteries. Sleep apnea, which is really one of the number one killers of bariatric patients, as it can result on death at home or on the highway, is often improved dramatically and allows patients to resume their normal sleeping arrangements at home. The overall death reduction is about 89% at 5 years. So people tend to live longer, live healthier, and live happier, and it happens very quickly without long term medication usage. In our practice, we're happy to introduce and utilize the Orbera system for non surgical weight loss as well. No cutting, no overnight stays, and a reversible procedure. The gastric balloon system involves placing a balloon endoscopically within the stomach. The balloon is then inflated, and this creates a sense of fullness and satiety. Along with this sense of fullness and satiety, obviously, someone will eat less. We typically can remove that balloon at 6 months, and people can look at long term success with about 25 to 30% excess weight loss. It is not indicated for morbidly obese or super morbidly obese individuals and is often utilized in a lower weight class of patients with a body mass index between 30 and 40. Speak with your surgeon specifically regarding this and if you're a candidate. To get to bariatric surgery, there need to be specific criteria met by the patient. patients will undergo evaluation by a cardiologist to see if their heart is in appropriate condition. Patients will often see a lung doctor to rule out sleep apnea and deal with any pulmonary issues, as they are often short of breath and have poor pulmonary reserve. All patients, as required by their insurance companies as well as the doctors, will undergo a psychology evaluation and be seen by an internist or their family physician to review all this data and undergo a clearance for surgery. Routine lab work, such as blood counts, chest x ray, are all important prior to surgery, and a medically supervised program with a nutritionist is mandatory as well. All of our patients will receive a minimum of 2 weeks of, I call it, crash diet prior to surgery. We use a regimen of high protein, low carbohydrate protein supplements called Robard, ROBARD, and utilizing this for 2 weeks prior to surgery typically results in 15 to 25 pounds of weight loss, which improves blood sugar, improves blood pressure, decreases liver size, enhances breathing capacity, and overall results in a more stable patient for surgery and one who recovers faster. Insurance is always an issue with any procedure. It should be a covered benefit within your policy. Please inspect that before you come see your surgeon. Network benefits are critical to maintaining coverage.
Thank you so much, Dr. Peters, for that presentation. That was incredibly helpful. And now, if you don't mind, we want to shift into a few of the most common real-life questions we hear from people who are considering weight loss surgery or just starting to explore the idea. Now, you touched on a few of these, but we wanted to let you expand a bit more. So let's start with one of the biggest reasons that people look into surgery in the first place. Obviously, how can it improve their overall health? For anyone listening who may be newer to this topic, can you briefly explain what comorbidities are, and then talk about how soon patients typically see improvement or resolution in things like diabetes, high blood pressure, or sleep apnea after weight loss surgery?
Absolutely. You're actually going to see improvement prior to surgery. Your comorbid conditions are other ailments that you might be taking pills for currently. You might have an appliance to sleep with currently, or your general state of well being, or something that's bothering you that you may not even have brought up with your physician. These are ailments that go along typically with being obese or comorbidity. When you see the nutritionist, when you first talk to the physician, you're obviously undergoing a change intellectually. You desire a change for yourself. That in and of itself is going to start to make you feel better. There's motivation there. After that, uh, when you start to initiate some of the processes the doctor recommends, such as changing the quality of your food source, all right, removing some of the toxic intake from your daily regimen, um, certainly the preoperative diet where you can lose 15 to 25 pounds. These things are all going to start to help you improve. But let's say none of that was in play and you simply had surgery. You're going to see improvement within 24 hours. Rapidly, fluid loss is going to create less tension in the skin and the legs and the abdomen. There's going to be a rapid dissolution of adipose tissue. And as that goes away, there's going to be less pressure in the abdomen and on the breathing, and also in the spinal canal for people who suffer from headaches. It opens the airway, the nasal passages, as all those cavities open up and oxygen starts to get to the system. So, how fast are you going to see it? Even before surgery. How soon after surgery? Within minutes to hours.
Another question that comes up a lot, especially for younger patients or families thinking ahead, is around fertility and family planning. Can patients get pregnant after weight loss surgery? And are there any general guidelines around timing or things that they should be aware of?
You know, it was interesting. People would come to the office and say, "Look, I know I can't have babies after this surgery. So, and I'm okay with that. I don't really want babies." And sometimes you get looked at like you have three heads, but I would look at these patients like they had three heads. And I was taken quite aback. I don't know where this information was coming from. Patients can certainly have children after bariatric surgery as much as they can have after a hernia surgery or a gallbladder surgery. It's no different. Um, There are issues with respect to the timing of getting pregnant after surgery. And honestly, you can get pregnant very easily after the surgery because the weight loss has occurred, the estrogen levels have changed, the ovaries are putting out eggs much more frequently and of a higher quality. So we have had patients get pregnant within 2 weeks of surgery who'd been trying for 2 years because the preoperative weight loss and that early postoperative weight loss I talked about have occurred, and the comorbidity of infertility changed that rapidly. Okay. So, can they get pregnant? Yes. Should they get pregnant right away? No. Bariatric surgery is like having a child. You've got to change your pantry. You've got to change your refrigerator. You've got to change how you shop, where you shop. You've got to get used to your new system and how you're going to give it nutrition, just like you would a child. And once you've really got that down pat, about a year to 18 months is when we recommend entertaining adding to the family.
Of course, people, once they start seriously considering surgery, the financial side is usually top in mind. So, do most insurance plans cover weight loss surgery, and what does that typically depend on?
Absolutely. You'd be surprised. Most insurance companies, over 99%, cover bariatric surgery. Certainly much more than they cover the bariatric medications. All right. So we're not having any trouble with insurers covering gastric sleeve, gastric bypass, duodenal switch, gastric banding. The criteria are dead set. They've been long-standing, well over 30 years now, and it is a routine part of healthcare for people suffering from obesity. So, aside from a copay, your insurer should typically cover this.
And before surgery even happens, there's usually a process to make sure patients are fully prepared. How long does the preoperative process usually take, and what are some of the key steps patients can expect along the way?
Back when I started over 20 something years ago, there were insurers who would make the patients wait 6 months and have a period where they would be seen by the psychologist multiple times, by a nutritionist an excessive amount of times, undergo all the workup that we spoke of, and then repeat some arbitrarily. 6 months was excessive. And over the course of these 20 years, it has now been trimmed down. And most insurance companies do want all the appropriate physiologic preoperative workup, heart evaluation, chest x ray, blood work, etc. However, that doesn't mean we should have surgery in 1 week. We want patients to be ready psychologically and with respect to the information they need for success. So we recommend certainly the psychology intervention as well as at least 3 visits with a nutritionist so they can understand the difference between a protein, a carbohydrate, a fat, what vitamins are appropriate, and how often they should be implementing this in their life.
And then comes the part people are often both excited and nervous about the recovery. So, what does recovery generally look like after bariatric surgery, and how soon can patients expect to get back to normal daily activities?
Again, having worked in this industry now for about 20 plus years, it's been amazing to see what's changed. Initially, patients were in the hospital 4 days, pain pumps with button activations, lots of narcotic use. And over time, certainly our technique has improved, but how should patients be managed surgically, not just with respect to bariatrics, has changed dramatically. The utilization of pain medication that's non narcotic has been a boon, actually. They're getting quality pain relief with rapid recovery and more rapid recovery by instituting early rising, walking, deep breathing, and generally getting out of bed and getting moving. They feel better than laying in bed. So, again, our patients are typically done in an outpatient surgery center. They're up and walking within 30 to 45 minutes after surgery, and they're leaving the surgery center within 5 to 6 hours, not as a driver, but as a passenger in a car, and often traveling good distances for a safe trip home.
Well, thank you, Dr. Peters, for breaking this all down in such a clear and approachable way. These are big decisions, and having honest, straightforward information really helps people feel more confident taking the next step. So, once again, thank you.
Thank you, Phil. I appreciate it. Everyone, again, thank you for coming out and watching this afternoon or evening. And from wherever you are, we can't say that we appreciate it more. If you'd like to get in touch with a bariatric surgeon or someone to talk to you about how to manage your problems with obesity, please reach out to the Christiana Institute of Advanced Surgery. Our website has easy access at www.creos.com. You can can simply add your name and phone number there. We will contact you within 24 hours to be seen by any one of our surgical specialists and or medical specialists. Now, as always, have a safe and healthy evening.